Tēnā koutou katoa. Thank you, Nick. That's a very lovely, warm welcome. Things like this are really dangerous for me because even having spent yesterday here and now even just from Claire's talk this morning, I have already a million ideas to take back into my organisation. So I'm known usually as a menace when I go back to work after things like this. But I'll start by giving you some organisational context, and really what I wanted to do with this 15 minutes is talk to you about some of the practical ways that we're bringing design into health, and to show you what that actually looks like in our context at least. So just to tell you a little bit about our organisation, Waitematā DHB is one of 20 district health boards in the country, for those of you that are less familiar with New Zealand health. The government devolves its funding essentially into 20 district health boards. We're the largest by population, so we have about 630,000 people in our district, and that covers all of North and West Auckland, which is a really interesting playground because North Auckland, for example, is really affluent. It has a really fast-growing migrant population. West Auckland has some of the lower socioeconomic areas in the country, so we've got huge disparity in the different populations that we look after. We have a young and fast-growing population, so that brings with it a whole different set of questions around engagement. How do we make better use of digital technologies? We have quite rural populations in the far north of Auckland, so sort of doing things that prevent people having to come to central hospitals, for example, is becoming increasingly important, things like telehealth. We also have a really diverse population. So there was a fantastic report done a few years ago by May Chen around super diversity, and essentially sets out that Auckland City is about the fourth most diverse city in the OECD. So we have over 200 ethnic groups now, over 160 languages spoken. So really understanding different cultures and being culturally competent and culturally safe is really, really important. So it has been for a long time, but now we've got real pressure to get it right. And one of the things, I love having provocative conversations in my workplace. One of the things that we talk about a lot is health literacy. And historically, conversations about health literacy are about how do you get the public to understand our health system. And actually what we're trying to do is flip that on its head and say, well, what responsibility do we have as an organisation to be health literate, to really deeply understand our communities and design with them, which as an anthropologist, that is what gets me out of bed to work every day. So that's the sort of stuff that I love. So that's a little bit about our organisation. So the part within that I work in is I3, the Institute for Innovation and Improvement. We set that up in December 2015, so we're in it'll be our 4th anniversary this year. And really what the Institute started out as is bringing together anyone that was involved in quality improvement. So we have a big organisation, 7,500 staff almost now, and lots of people all over the place were getting involved in patient experience activities, staff experience, although we've historically been less good at that, or sort of quality initiatives. And what we want to do is bring them all together, one, so that they can support one another, but actually to make it easier for the organisation to have a one-stop shop where we want clinical teams and other parts of the organisation to say, we've got these cool ideas, we know what really matters to patients, we know what really matters to staff, now we know where to come to get help actually implementing those things. So that's sort of how it started, and over time we've grown, so now we have about 40 staff, and there's a mixture of social researchers, clinical and non-clinical people. We've got web developers, designers. We're very, very fortunate. Any of you that have had the absolute pleasure to meet Cassie, we're very fortunate to have Cassie, who works both with the Good Health Design team here and with Waitematā DHB as our design fellow, so a permanent fixture in terms of bringing together the university designers and health, which has been really fabulous. But we have 3 working principles, so all of our work is guided by these 3 principles. The first is that everything's data-driven, so show us the evidence, essentially, and that's really important in terms of clinical engagement. So clinicians love data and they want evidence. What we're also doing is sort of coaching that data isn't always quantitative. So actually qualitative data and speaking to people about their experience is equally valid, if not more so in some contexts. So the first thing is just gather information and use it to measure the impact of what we do. The second is that everything we do is either led by clinical teams or our community. So we don't actually have any projects underway, nor have we, where the I3 is driving it and going out and saying, this is what we're going to do to you or for you. It's actually you do it and we will work in the background to support you. And then the third is that everything we do is done from a person-centered design thinking perspective. So that's a sort of overview. One of the things that we've been doing a lot of is getting the rest of the organisation to think about stakeholder engagement. And any of you that are familiar with quality improvement will know about RACI models and sort of various stakeholder mapping. This is a model that I use quite often because it's actually quite useful to just get people to understand where they are with particular work. So whenever we're developing up a new piece of work, what we say to people is, where do you want to situate yourself? So are you part of a working group? And we try to keep those small, agile decision-making groups, but making sure that people have a representative voice. So on that group, you would still want people that are well networked into different communities. And the other thing we're very keen on doing is bringing together lots of different people in and outside our organisation. So thinking about the concepts like co-design, I can understand where these things come from. So co-design's really lurched a bit in health to be about engaging patients. And that was necessary because we were historically really bad at doing it. So it sort of comes from a deficit place. And what's happened in the mindsets of lots of health workers is then it excludes them. So when we talk about co-design, often staff think, okay, this is about patients. So that's using terms like human-centred design, person-centred design is quite useful because it brings the collective back together. So that's what we'd look for in our working group, is a sort of a well-networked collection of people. But then what we can do is say, well, then who are the stakeholders around this work? Who needs to be involved and consulted? And then who are the people that still want to have a contribution, but really it's for information only? And what's useful about models like this is you can offer it up to people and say, where do you want to be? i.e., if you're a really busy health worker, one of the penultimate problems we have is releasing people's time. So it's really hard to get people to engage. And we've done some fabulous work actually with Steve's team about how do you engage people outside of a 2-hour focus group. And so what we can do is use models like this to say to people, where do you put yourself? So if you don't have time to do work, then you're not going to be on the working group and perhaps not a key stakeholder, but you can still be informed and contribute. So this is really about helping people map out where they want to be in any particular piece of work. And then the first thing we've got to do is listen to people. So we have 3 key questions that we ask patients and our staff and our wider community. The first is, what matters most to you? So what do you actually care about in terms of health and designing it? What is working well so that we can do more of it and keep those things innovative and sort of at the forefront of what we're doing? And what's not working? What is it that we either need to stop altogether or that we need to fix? So those are sort of the key questions we ask. We have a real over-reliance in health on surveys. So this is really about trying to get people to rethink how it is we listen and hear from people. Surveying has its place. I'm an advocate of surveying and use them a lot myself. And now we've got electronic systems. You can survey people en masse. We can survey our entire district if we want. Really importantly, what we've just cracked this year is surveying patients about self-reported outcomes. So that's been done all over the world, sort of with varying utility. But we've actually put in place a systematic program that will now roll through our entire organisation. So every clinical service in time will be asking patient-reported outcome measures. And what we've been able to do this year is integrate survey software, which takes all of the administration out, with our clinical records. So now when a patient completes a survey, within 5 minutes, that's visible to a clinician in their health record, and that means we can talk to them about things like their quality of life and other measures. So surveying is actually really important. So it's one tool we have, but it's not the tool to use all the time. So what we're trying to do is get our teams using multiple methods. So we're collecting patient stories, and we started a program of video stories a few years ago, which are all on our website if you're interested in viewing them. Anyone who's consented to have their story shown publicly. They're amazing teaching tools, which again just are different examples of people telling us what matters most to them, what's working and what isn't. I'm using stories a lot, so I'm doing my PhD at the moment on Maori experience of hospital care, particularly in the context of colonisation. So what is the contemporary impact of colonisation on Maori experience of hospital care? And that absolutely involves just going and being with Maori members of our community, listening to their stories and sort of teasing out what it is that works or not. And what would the system look like if it was set up by Maori for Maori? What would be different about it? So that's been really fabulous. Then we have lots of other methods that we use. So we have what we call in your shoes and in our shoes sessions, which are sort of structured group sessions where we just listen to people, tell us life in your shoes. For staff, we ask what makes a good day, what makes a bad day, so that we can drive more good days at work and necessarily do less of what makes bad days. We had a fabulous session yesterday with Hannah running the communicating in colour, which is actually people using colour to actually articulate what a good day and a bad day looks like visually. So that was really fabulous. And then we have other things that are fairly standard for any organisation. So we have complaints, we have compliments. We're much better at analysing complaints than we are compliments, which is odd because we get infinitely more compliments than we do complaints. So we've sort of got a little bit of a organisational focus on what's not working, which we're trying to shift. And more recently, we're using observational methods. So I obviously have a bias towards things like ethnography and observation, but it's really fabulous. One of the exercises we did in the last couple of years is take charge nurses, so the nurses that are in charge of particular wards, and just swap them, put them in a different ward and just get them to observe what does it look like, sound like, smell like, is it calm, is it chaotic, is there a welcoming face at the reception desk, etc. And what was really interesting about that is, one, you get lots of quick fixes. So one example that springs to mind is people were going into a particular ward and the sluice door is open, so it's not the sort of thing the public want to be seeing. So that's really easy to fix, or that we absolutely know having a receptionist at the desk is really important, but we didn't have cover for ward clerks when they're on breaks, so that's changed. But then what you start to get is much more detail about what's important. So we actually know that sort of having a calm environment is really important to people. Having a named individual that cares for you is really important to people. So those sorts of observations give you much more insight than sort of just surveying or just the storytelling. Actually going, what is it that's actually going on in the physical environment? And importantly, all of those tools that we're much better at using for patients, we also now use for staff, which historically we didn't do. So the last big staff survey we did was 2011. It's crazy. So we've had a long history of not listening to people. And so now actually we've descended on them with all these multiple methods. So we absolutely know now what matters to our staff and what they think is working or not. This is just one example of a research project that we did. So this is sort of taking the listening to the next level. We worked with Atlantis Healthcare, which is an organisation that employs lots of health psychologists, to do a collective piece of research with us around mapping out, this is a patient journey through our upper GI cancer service, so sort of any cancers from here up. And basically there was 3 bits to it. The first was to map out what actually happens, so what is the structural flow for people going through our upper GI cancer service. And one of the things that they wanted to do was evaluate a one-stop shop. So they'd put together this clinic where now what you do is you come in for a day, 6 different specialists come to you and give you lots of information, and then rather than coming in 6 times. So they wanted to see, is that working as well? Interestingly, because we thought people would much prefer that, it wasn't the case. So people actually like coming in more often because they feel that they're in the system, we know they're here, rather than being seen once and having a longer delay between seeing someone. But then, as we had lots of people engaged in this research, it was a good opportunity to then overlay the emotional context. What do people feel as they go through that journey? And then, so this graphic is actually based on people's feedback. So they described it as a road trip. You can see at the top, when you first get diagnosed, it's like falling off a cliff, and you are totally at the mercy of the health system. So that's the parachute. And so what we know is that that moment is so critical for people that we have to work really hard to build a relationship of trust. If we get it wrong then, the whole journey fails from henceforth, basically. So we developed this up, and everything on this page, it looks really busy, but everything means something. So even the telephone wires, one is about the flow of clinical information, one is about the flow of patient information. You can see here sort of under the parachute, there's a poor GP struggling to find any of that information. Then people move through the system and they may end up somewhere like in our intensive care unit. That's described as being first class on an aeroplane. You've got one person looking after you. Your family is sort of easy flow in and out. Then suddenly you go to a ward where there's one nurse looking after multiple people, lots of families in and out, lots of kids, lots of noise, lots of beeping, lots of whirring, and so that's like being shunted to cattle class in the plane. So it was really interesting to sort of understand exactly what people go through. And then what we did, which is the third bit, is say, well, work with us to co-design the optimal journey, what should happen. And what came out of that was really interesting, is people didn't tell us structural changes. So they sort of said, you know best, you do it, and we're happy to go through the system, we'll tell you if it's not working. But the optimal journey was a series of statements about things we must get right, like the trusting relationship, like communicating with people in the right way, with the right tools, at the right time, and with methods they can dip in and out of and be in control of. So it was sort of it was more of a list of things we needed to understand, which was really fabulous. So that's an example of sort of doing some detailed listening. A practical example that we've just done in the last couple of years is we went out and did a quick environmental scan. We have 2 main hospitals. We went out to patients on multiple wards in one day and just said, what's the single thing we could do to improve your hospital experience? And essentially what people said is that hospital is really dull. So give us the internet, give us movies, games, books, whatever. So we thought, let's take Air New Zealand's in-flight entertainment experience and do in-flight entertainment in hospital. So we've developed up, we ran a design sprint last year, which turned into a mock-up that was tested with patients in situ, that basically now will be iPads at the bedside that have a range of entertainment options. That part's actually quite easy. But what we thought is if we're powering up the bedside and turning beds into smart devices, then actually the sky is the limit. So now what we're creating is a patient engagement system which has two-way information flow, so people can get generic health content. They'll be able to, in time, get personalised health content. So the device will at point say to you, hi Jay, welcome to Ward 7. We know you've had a hip replacement, so here's some content about rehabilitation. So actually really personalising it. And what people have also told us, again, this is co-designed with patients, is they want to share that information. So now there's the ability to share that with your loved ones, and as things happen to you in the journey, people around you that are important and you've selected what is shared with them, they will also get updates. So it might be, in time, that might be live chat. It might be that a surgeon says, yep, Jay's out of hospital in recovery, all went well, now you can come in. So there's that sort of content that we're building. And then I wanted to just finish, I'm not sure how I'm doing for time, sorry, I usually need shepherd's crook, thank you. I wanted to finish talking to you about the work we've done with Steve and the Good Health Design team. So, and I see one sitting here, hello. Oh, 3, we had our inaugural integrated design studio this year where we literally brought designers into the hospital. And so we had 12 design students for 12 weeks, which was really, really fabulous, working on a range of different problems. The context for this is that the government's recently given us $220 million to build a small surgical hospital. That's unusual in New Zealand. Hospitals don't get built very often. Our executive team even said only in the last 2 weeks, we actually don't know how to do this because we haven't done it before. So we've actually got to get people in that will be able to help us work on this. So we had our integrated studio and put a range of options out to these design students, a mixture of product, spatial, and communications designers. One of them redesigned our engagement system. So we were thinking of spending hundreds of thousands of dollars building this thing with design agencies, and now we just have one student who can do it for us, which is fabulous. So this is in 12 weeks, we've got our mock-up engagement system. Thank you, Sarah. So that's an example of sort of communications design. And what was really fabulous about bringing the students in is giving them access to real life examples. So we put them in patient beds. They took over a 4-bedded room for an hour or two. What is it actually like? They spoke to staff, talking to patients, actually taking them around the environment. This is the physical environment. This is the limitations. These are the possibilities. They were talking to their own families about different solutions, but also what it does for us is brings in design expertise into an environment that historically is not creative. So the reactions to staff were amazing. We had nurses that have been working for 30, 40 years saying, oh my God, I've been working in this environment all the time and I've never thought about that. It was really fabulous. So a couple of other examples, this is one of my favourites, is this light installation. We have a very odd, it's going to be a rectangular building with a light well in the centre that people may or may not be able to access. We don't know yet. So what do you do with sort of dead space other than cover it and have bird mess on it in time, is actually you turn it into a really fabulous light installation that moves with the flow of the building. So this is sort of an interactive thing that the pace of the lighting would speed up in the day when humans are moving through space, slow down at night into sort of calm twinkling stars. It was absolutely fabulous. So another example of how do we use the physical space to actually bring the outside in for people. They redesigned a bathroom, so we've talked about Claire's example of bathrooms, looking at things like making use of natural products. Why don't we have things like wood in the bathrooms? And there's lots of issues around things like hand hygiene. So we have our infection prevention and control team who will be very hot on topics like this. But actually, if you just lacquer these, you can still use the products and make sure that actually they're totally able to be sanitised. So it's, we just need to think a little bit out of the box with some of these things. Different hand railings in the bathroom. All of our rails are at set heights. There's light switches in the shower that require you to sort of bend and lean to access the light. It's actually quite bizarre, even thinking about it now myself. So thank you for the redesign of the bathrooms. They looked at patient rooms, the actual 4-bedded rooms, and this was the bit that struck, I've got a particular nurse in my brain. Any of you that have been into a 4-bedded rooms will see the beds just face each other. And the comment back from our design students was, that's really odd because you're looking up someone's body. That's really uncomfortable. And that's what these nurses are now thinking, that's absolutely right. So why don't we just angle the beds a little bit? We've got a medical device panel behind everybody's head. It requires staff to lean over you and access stuff is going on behind your head that you can't see. So we just make that a vertical panel beside the bed so you can see what's going on, the staff can access it. It's actually probably better in an emergency because you don't have a patient's head to contend with. So this is just, again, rethinking space. The family rooms were quite interesting. So we actually only redesigned our family rooms in the hospital a couple of years ago. And they look like, they're designed to be home from home, like a lounge. There's a big TV, the TV is the centre. As with many lounges, I'm not a TV watcher, so I don't own one. But there's a TV, there's a sofa facing the TV, and there's usually a table behind it with sort of 8 to 10 people that can sit there. So what that actually does is when a family is in there, they may feel quite at home, but then when you go in, it's like walking into someone else's lounge. So you've sort of wandered into your neighbour's house uninvited. So they just looked at how do you use different shapes and materials to still create a home from home environment, but actually let people have different spaces and sort of use the space together, but individually. So that's just a few examples of sort of the impact of bringing designers actually into the organisation. But I think in terms of the context for today about what is design for health, this is really it for me. So I think fundamentally it's about deeply listening to people, really understanding what it is that matters most to people, what do they want from their health service. And I think if you put patients and whānau in control of health, they will design it to be fabulous. No one's going to design a crap health system. So just let people do it and empower them with the tools to make it possible. And I think particularly on that note is about bringing people together. So, and collectively for everyone in this room, I think that's one thing we can do when we go back to our different organisations is start to break down the structural barriers that just stop us working together, whether it's ethics, whether it's policy, whether it's funding, just start to remove the boundaries. They shouldn't really exist. We can just all work harmoniously together and co-design fabulous health solutions. Thank you.